now, so just asked everybody to
awesome.
plug into chat where they're from and do a little introduction of themselves.
Nice.
Looks like we have a small group, so
All
I
right.
hope
Should we jump
everybody's
in?
in the mood to start sharing. Yep, go ahead.
Awesome. Yeah. Yeah, I'll do our famous calling on people if we need to. So we'll jump in, guys. So we're actually already, if you can believe it, the time is just flying by. The second to last installment of this series, and a lot of good things have come out of it. We've had great feedback, and this has spawned actually some additional work through some requests and just through some quality measures that we're tracking. Just in the background, so everyone's aware, we're going to continue doing some work with specific nursing homes and facilities and do some really targeted quality improvement work. What's nice is Mount Pacific has just an amazing wealth of data. And so we've kind of been tracking, antipsychotic use and mobility measures, all kinds of health measures, all kinds of those quality measures. And so this is one way of trying to improve care. And then we'll actually specific facilities and really look at measures and really quality metrics. So I just want to throw that out there. Our work will continue. So got the statement about continuing education for nursing. We got our disclosures. Nothing has changed. Any announcements we need to share with folks?
Just along those same lines that you talked about, some quality metrics, we will be moving forward with, in conjunction with the Alzheimer's Association, with getting some technical assistance around how primary care providers can start performing and billing for, the important word billing for, cognitive assessments in primary care. So that's a team-based approach to care. And that's not going to probably happen like next week or anytime soon, but look for that information. We will for sure be sending it out through all of our usual contacts.
Wonderful. Yeah, and there's really tons of ways we can support work in that scenario. So things like the annual wellness visit, which Medicare supports and our primary care providers can do with our elderly patients, whether they're at a nursing home or coming in as an outpatient. So we can build in cognitive screening into that. There's all kinds of things we can do. So we can. So that's a great point. Anyone else? I mean, and this is announcements from anybody, so it doesn't have to just be from related to this talk. But if there's any good news you want to share, any wins you've had, any any kind of new interesting resources you learned about, definitely jump in anytime. So today, like I said, second and last installment. So we're focused on cognition and comorbidities today. So in the last few, we're really trying to focus on care management, trying to get down to brass tacks, really be concrete, and see if we can provide some clear guidance. So cognition and comorbidities. So today, we want to explain the importance of limiting transitions and keeping Alzheimer's disease patients out of the hospital. This is something that comes up, very frequently. In fact, yesterday I had a call with St. Peter's Hospital in Helena because their providers are the medical directors for the local hospitals there. For the local nursing homes, is for 4 major nursing homes in Helena. And this is a big topic that comes up when I'm taking care of patients in nursing homes, and then at the kind of administrative level is minimizing transitions, is a huge way to prevent delirium and behavior and agitation and those kinds of things. Because when cognition starts to decline, it's really, sometimes amazing, but we have to remind ourselves that someone has cognitive impairment or in early stages or moderate stages of dementia, simply waking up in a new place can cause a big problem. And so those kinds of transitions are a big thing to focus on. And sometimes it's easy to forget that just something seems like simple like that can go a long way. List of commonly occurring comorbidities. We're going to talk through those and how to simplify treatments and environment. Doorway thoughts. So when it comes to treating cognitive symptoms with pharmacological options, so like with medications, we don't have a ton of options. We think about the stage of disease, we think about the potential benefits, we think about the side effects. In these in particular, these are talking about mostly donepezil or Aricept. That's been around the longest. That's an acetylcholinesterase inhibitor. And that's the main medication approved for Alzheimer's disease. In the early 2000s, memantine also was approved for Alzheimer's. And that's more for the moderate stage disease. And so the big thing is donepezil works better the earlier you give it. And so it's ideal to get it very early in the process. Namenda is more for moderate stage. So that's where the stage of disease matters. It's not infrequent that I see patients that have mild cognitive impairment or very early stage or very functional, and they're on Namenda. So it's really not appropriate to see that. There just is no evidence to support that's beneficial. We're trying to minimize medication exposure as needed for obviously preventing side effects. There's better evidence to give earlier donepezil. They're totally different medications. So that's when we're thinking about stage. And then the potential benefits. Well, if you do start, the earlier you start, if you start donepezil early, the studies following people for years shows that they will stay out of the hospital or out of a nursing facility. They'll maintain functional independence 2 or more years longer than people that don't get the medication. So that's a pretty motivating statistic and a very well data supported one. That being said, it's not without its side effects. And so it can lower your heart rate, it can cause some dizziness, and it can cause some GI upset. And so if someone has a really, really bad, there's a couple of things to do around it. There's other formulations, but those are all considerations. In general, I'm not going to start a 90-plus-year-old on donepezil, even if they're, getting into the early stages of dementia, because the side effects really become more heavy at that age, right? And so we really want to have that. Those are the kinds of conversations we have. Those are the main dementia medications. Then not to mention all the behavioral symptomatic treatment. So if someone's having significant behavioral change, we were thinking about antipsychotics. Well, those come with a black box warning right on the label. It says, if you're over the age of 60, when you start an antipsychotic, there is a real increased risk of just sudden stroke and death. And so, in practice is that it's there. That's why they report it. It's not necessarily common, but those are all things we have to really consider and, disclose and discuss with the family. The mainstay is the lifestyle interventions. And dementia and cognitive change is often the best motivator I've found for families to really start pushing on the lifestyle interventions. And so this is a time when I usually see people find their motivation to start changing their exercise habits, their diet, weight loss, avoiding isolation. It's critical. And have to be creative during COVID, have to be creative if you're in a facility, but it's critical that happens for our brains. Sleep, boy, I harp on sleep. There isn't a single assessment I don't do, or I do that does not involve a focus on sleep. So I will not allow someone to not improve their sleep, if we're, starting treatment. And then preserving overlearned behaviors. And so, that's really talking about, behaviors. So basically, if you've learned certain coping skills as you've gotten older throughout your life, like even simple things like how to keep a calendar, right? How to track things rather than just, relying on spontaneous memory and just things occurring to you, but finding those good behaviors that'll help you maintain your independence longer. Those are the kinds of things we want to preserve. Any thoughts or comments? Got it. Should I turn my camera off? Is it coming in patchy? Okay, I can turn it off. Sorry, guys. I can move. If it's patchy, just let me know. I'll move around. Living arrangements for persons with dementia. And so here's some interesting kind of living arrangements versus MMSE score. So mini mental status exam. So just a rough guide of how impaired you are depending on your score, and 30 being the highest score on the left, 0 being the lowest score. So, if you're kind of in the 20s, you're kind of more mild cognitive impairment. You start to get to low 20s and teens, it's like early stages of dementia. And then down here, more moderate severe dementia. So just to give you some orientation around that. So intermittent supervision living at home, right? If you're still pretty functional, you can have some intermittent supervision. You're kind of then transitioning to having more supervision. You're still at home. As you slipping a little bit further down, you could benefit from daycare or personal care, assisted living. As you kind of start to, and these are depends on where you are. These are all interchangeable. I mean, you don't have to, like, you might have a really nice, easy assisted living. Great, use it. Or you might be somewhere it's easier for you to just hire someone to come in the house. But the point is, in those 20s, you're really starting to need some touch base, right? Like, you're probably going to maybe start making mistakes managing your medications. You might not be eating the best. The diversity in your diet might go down, things like that. And then once you're into the teens, and you have Alzheimer's, you're really looking for probably a little higher level of care. So you don't necessarily need skilled nursing right away. That depends on comorbidities, which we'll get into. You might have other issues, but if you're otherwise healthy, you will be looking for some kind of facility that has the ability. What's nice is a lot of facilities now have that kind of the graded approach. So you can go in as assisted living, then as things change, you can get into the skilled nursing side, and then eventually even memory care. So that's kind of a model I'm seeing spread, with new facilities opening. So average annual per person Medicare and Medicaid spending. Seniors without Alzheimer's disease, $7,400. Seniors with Alzheimer's disease, look at the difference. CMS is extremely motivated to treat and improve care with Alzheimer's because, honestly, it helps the bottom line. If we take better care, and we anticipate, these numbers are actually a lot less. It's not a given that if you have Alzheimer's disease, you have to spend a lot more. If you think about it, when we don't intervene early, think about how many more times that patient's going to end up in the hospital, in the emergency room, and in expensive situations. That's a lose-lose because they're going to get more agitated because they're in the emergency room. So their quality of life is worse, and it costs more money, and everyone's upset. So this is where, luckily, in this situation, money incentive can line up with quality of care and quality of life. So we can use that as an incentive to do this work. And Medicaid spending is on average 23 times higher for seniors with dementia. I mean, so it's pretty staggering. In fact, when you do kind of cost adjustment in terms of looking at chronic conditions, this is the largest bill we face as a country now with our aging population. I mean, this is the biggest impact on healthcare. So here are the medications, which I was starting to touch on, and I'll go into a little more detail now. And so donepezil, again, approved for mild disease, right? Memantine, see, moderate to severe. So really don't want to be seeing memantine until you have a pretty significant dementia. Rivastigmine and galantamine just came out a little later than donepezil. They're the same kind of medication. They're all acetylcholinesterase inhibitors. Doesn't really matter. I always start with donepezil because it's the cheapest. It's been around the longest. It's the easiest. The nice thing about rivastigmine is it comes in a patch form. You can see here listed. And so if someone is one of those people that has stomach upset with donepezil, I'll often switch them to the patch, and that'll usually resolve it. And so that gives you an opportunity to still get the medication, even if you're having GI issues. And they're all available. You just take them once a day. They all have a titration you have to be slow about, because you don't want to, if you jump into the full dose, it's pretty much guaranteed you're going to give somebody diarrhea. So we don't want to do that. So they all have a dose escalation, and then it kind of lists the clinically effective dose. So bottom line is you start everybody, and over the course of a month, you ramp them up to the full dose. And if they have a GI upset, you can kind of switch them to the rivastigmine patch. And then once a dementia becomes more moderate, we start memantine. That also ramps up, and you end up at 10 milligrams twice a day. So 20 milligrams total. Memantine, you end up at 10. There's donepezil, you end up at 10. There's actually evidence, though, with Lewy body dementia, Parkinson's, things with alpha-synuclein pathology, that higher doses can be helpful. So in those cases, actually, we pushed it to 20, 23 milligrams donepezil. So we go quite a bit higher for certain pathologies, but that's getting into the weeds. There's some emerging evidence for that. Tips on management. Capacity decreases as disease progresses. So as someone has increasing dementia, their capacity to make their decisions, financial, medical, otherwise, decreases. Capacity, remember, is a medical term. So as a physician, I can deem someone to have capacity or not. I cannot deem someone to be incompetent. That competency is a court decision made by a judge. So I just want to be clear about the difference in those two terms. Sometimes we throw around competency. No medical provider has any authority to make a competency decision. That's the law. So if you wanted to have a guardianship and change competency permanently, that's just a court process. Yes, well, they look at the medical notes, and of course, that will weigh into it. But capacity, I can, for example, see someone say, in that moment, they do not have the capacity to say decline the surgery that's life-saving. We could say that, but I can't say they have no capacity for anything at all. I have to be, we have to be very specific. So it's helpful in our facilities and in our care for patients to be very clear. This patient does not have capacity to make financial decisions. So someone needs to manage their money, or they don't have capacity to make medication decisions. So those are the kinds of things we do. Environment should contract as disease progresses, right? So this is the minimizing transitions. So we want less exposure to new things as the disease progresses, simply meaning just to have stability for someone. That's all. They should still get out and get into nature and all that. Doesn't mean they should not do anything. But the staple, the routine should be much clearer and less likely to change. And of course, all kinds of challenges with that, but that's goes a long way. Fewer medications. So as someone with dementia, if they're on donepezil and memantine, let's say, and they enter that severe stage or they're much over 80, we start taking it away. The medications have done their thing. We don't need to stay on it until the end of their life. And we really start peeling away. I mean, do they really need to be on a statin? Do they need to be on a Lipitor, for example, when they're 90 and have severe dementia? Probably not. Do they need to be on that aspirin? Probably not. Blood thinner, because the likelihood they're going to fall, right, and potentially bleed if they're on a blood thinner is much higher than the prevention of the stroke that it's trying to do. So you understand, as people are aging, that risk profile changes. All of a sudden, those decisions we're making about medication treatment are different. So, I'm not going to treat them like they were when they were 55, and I'm trying to save them from a heart attack. And so fewer medications is critical. And as they get older, as you know, the liver and the kidney, as everything's aging, side effects go up, and if what happens, we've all known what an elderly person over 80 who's gone in for anesthesia for a procedure and what happens, right? It can take them weeks to get it out of their system. It's a huge disaster. And all they wanted to do was, get this little tiny procedure to do this thing. We have to really rethink that. Is this procedure really necessary? Because boy, does it have consequences that may never clear up. Quality of life prioritizing that, right? Constipation versus bone health. So again, do I really need to start someone on bone medication, at 90 years old versus really focusing on their constipation? We don't want to lose ourselves. We don't want to just blindly follow guidelines. Vitamin supplements and pill burden. Yeah, again, someone who's 95 and has dementia, trying to get them to eat, have 40 pills a day, not going to go well. Iron therapy versus constipation. Again, do I really need that person to take iron? Because it's going to have consequences. They're going to be really constipated and they're going to have stomach pain. And so this is the way we want to start thinking when we're treating dementia, because comfort, being physically intact, limiting transitions, that's going to go a long way. Rather than let's say, staying really hyper-focused on, wait a second, your vitamin D level is low. I need to treat that. It's a consideration, but we got to have it in the context of the big picture. Any questions? You guys jump in. Excess cost for older inpatients with clinical complexity, cognition, comorbidities, and complications. So dementia and any one hospital acquired complication were equivalent to 15 and 14% respectively, the mean extra length of stay cost for a study population. Right. So dementia and any one hospital acquired complication so dementia was equivalent to 15% of the mean extra length of stay costs. So admission severity and other comorbidities were equivalent to 5 and 4% of the average extra length of stay costs. Consequently, patients would need to have 3 times the admission severity score or comorbidity index to generate equivalent extra costs as having dementia or one complication. So that's what they're trying to say is having dementia is the same as having 3 times the admission severity score or comorbidity index. That's the kind of burden dementia carries when you're coming to the hospital. So year of age, sex, or surgery had minimal impact on extra costs. So is that interesting? Year of age, sex, or surgery had minimal impact. It was, and it's just to put in a context, the dementia alone adds huge impact to how you're going to do and how long you're going to be in the hospital and how much it's going to cost. So again, these are all reasons we're trying so hard to keep people out of the hospital. Okay. And so if you look here, this is just a graph from the same paper. So this is from the +1 paper. So extra costs on the left, right? So that's in dollars, and then type of complexity. So dementia present, complications, admission severity, cost weight, comorbidity. This is a Charlson index, and then age, years after 50. I mean, look at that. Dementia, look how huge that is versus complications. So dementia has more cost than if you have a surgery and have a whole bunch of complications from it. I mean, that's amazing. So if you go in and you have a surgery, and you have an infection and it kind of just turns into a mess, it's still not as much of an impact as simply having dementia. I mean, that to me was surprising to see that. And then the admission severity, score. So you can see it's like 3 times that of just dementia is just 3 times, that triple measure, which is the black area. So does everybody understand this chart? It's just really pointing out how motivated we are to keep people out of the hospital with dementia, and really rethinking, again, elective procedures. Does that patient really need that elective procedure? Like, do they really need, I don't know, this like something on their skin removed or something? I mean, whatever it might be. I mean, really rethinking what we send people into the hospital for. Commonly occurring comorbidities. So common. Remember, we talked about to have Alzheimer's mixed with vascular dementia, for example. Super common. That happens all the time. And so what goes along with vascular dementia? Well, hypertension. So systolic blood pressure being elevated. This is referring to this intervention trial that had an impact on cognitive outcomes by controlling blood pressure. We know now if you have any evidence of vascular disease in your brain, we actually want to be really aggressive with your blood pressure, much more aggressive than we normally would with, let's say, an average 70-year-old. So we're actually going to basically be as aggressive we would as like a 20-year-old, because we want their blood pressure to be much lower, because they've proven that their brain is just very sensitive to high blood pressure. Diabetes, osteoporosis, obesity, alcohol abuse, depression, social isolation, sleep disturbances. These right here will be the difference of drastically accelerating the disease and reducing, your quality of life and your length of life by years. So if someone is, let's say, 60 years old and has the early signs of dementia, that their life expectancy is going to be years different depending on these factors. So these are very motivating to make a big difference. Sensory deprivation. This is how I think when I'm talking to patients. I just think, are their senses as sharp as possible? Because that's what really matters. I want senses to be sharp. So wait a second. Are you wearing your glasses? Wait, you haven't gotten your cataracts addressed? When you do that, why aren't you wearing your hearing aids? You need to wear them. You're going to feel much better. I can't tell you how many patients I've had with behavioral issues that have Alzheimer's that don't wear their hearing aids. We intervene. I say, wait a second, they're not wearing their hearing aids. They start wearing their hearing aids, and that's all we do. And then later they're saying, oh, wow, they're much better. Their behavior is much better, and they're way less agitated. It just happened again yesterday. I saw a patient that started wearing his hearing aids. He's doing much better at home. Touch, proprioception loss leads to falls. So proprioception is the sensation you have. It's the nerves that go into your feet and your fingers to let you know without looking where the weight is, where your balance is. So for example, if your big toe moves up without looking, you can tell that it's moving up. When people lose their proprioception, you can move their big toe up and down. They have no idea. They're like, I don't know. Are you moving my big toe? Well, you can imagine that really impacts their risk of falls. And so we want to keep it as sharp as possible. So not just treating diabetes, things that cause neuropathy, but making sure that they're getting some diversity, some exercise, diversity of touch. So they're not just sitting there isolated all day. Taste, loss of appetite leads to weight loss and reduced immune function. So smell and taste kind of go hand in hand. They do get lost in dementias as you get older. So sometimes you just have to give people stronger tastes. And it's good to give them kind of challenges. So like put some flavorings and things that are stronger so that they can really light up that part of their brain. Some strong like citrus flavors, or spicy flavors, whatever they like, but something that they're really going to notice. And olfaction, smell, it's interesting. The olfactory bulb and the smell nerves are so fascinating because evolutionarily, they're separate from the rest of our senses. Vision, hearing, touch, taste, they all go through the main computer, the thalamus in the base of the brain, this big intersection point. Smell doesn't. Smell goes right to the cortex. Super interesting. So it bypasses that. So smell has like a very ancient direct path to the brain. And turns out early life loss of smell is actually very common in people with Parkinson's and other dementias. So it's really, it doesn't mean you're going to get it. So please don't think my smell is gone. Obviously with COVID, there's viral issues that can cause it, but it's really important to keep that as sharp as possible. Goals of care. So we're going to simplify our treatment strategies, right? Like we were saying earlier, pick your battles and your diseases. Do I really need that person to remember to take their Lipitor? Probably not, once they get to a certain stage. We want to reduce caregiver burden. So again, I want to pick my battles. I don't need the caregiver to check off the 30 boxes from the annual wellness visit. I really need to focus on one thing at a time. Let's get them to wear their hearing aids and just call that a win and move on from there. I don't need to make the caregiver, hey, did you check their blood pressure? Did you check their weight? Did you check their blood sugar? Did you check this? Did you check that? We want to just be careful what we're asking people to do, right? Because it can be really stressful, especially when it's not a given that the patient's just going to jump in and go along with it. So limiting the transitions, so home to hospital, nursing home to hospital, assisted living to skilled care. That's why I love these facilities or places where I push people to go early. So earlier the better. I don't want you to wait until you have a really bad dementia and then all of a sudden be in a big rush to move into a nursing home. That's not fun for anyone. So I push people to go earlier. Hey, okay, this is where it's going. So what's going to make sense? Let's get you into that skilled nursing, or let's get you into assisted living, because that's less likely you're going to have a transition when it's a hard time, right? So early transitions, the better. Getting someone somewhere where they're going to have the long-term ability to be cared for, rather than having to move to a different facility, 3 different times. So I really try hard to anticipate that, and I really do push families to help them feel ready and more accepting of this sooner. And so we want the person to function with minimal failure and maximal use of retained abilities. So yeah, you want a place where they're going to have encouragement to be independent. They're going to be supported. But at the same time, right, they're going to have the support they need so that they don't, all of a sudden, let's say they fall and you're like, wait a second, we don't have skilled nursing. You're going to have to move somewhere else just because you fell once. We want to avoid that situation if we can. So we just went through a whole lot of stuff. Questions? We talked about medications. We talked about transitions, lifestyle interventions. What are people's reflections? Is this all making sense? And do you have any specific anecdotes you can share?
Yeah, I put in the chat box about, if people have created, especially during COVID, when we've really been trying to decrease, people in the hospital and things like that. Was there anything unique that you implemented to keep people safer? I'm even thinking more telemedicine or other kinds of consults, or I'd just be interested to hear from the group what kinds of maybe unforeseen positive things happened because of COVID. Anyone? Dr. Gomi, have you increased the use of telemedicine in the nursing homes because of it? I mean, I know that you guys do a lot of telemed anyway.
Mm-hmm. No, we absolutely do. Yep. Yeah, we have a big, I mean, there's a lot of demand. So we are doing a ton of telemedicine. We're now starting to move towards like a hybrid model because with, which is naturally with challenges with staffing and whatnot, it can be hard to even get like the telemedicine to work. So we're trying to have some ability to do in person so someone can show up and you don't have to worry about showing them around and whatnot. But it is definitely increasing in use. And I think it's here to stay.
Any communication structures with your hospitals that perhaps were effective?
I think this is an area where like our visitation policies grew just from kind of common sense and experience. I think initially with COVID, we panicked and said, no visitors ever in these areas. And I think that just with experiencing people coming in, whether the patient has dementia and their family member has to accompany them to provide history or just to be there for support. But also, I think one of the things that we don't always think of is if the caretaker has to go to the emergency room, then this person with dementia has to go too, because there's not somebody to take care of them somewhere else and supporting that.
Yeah, so staffing is a big challenge in terms of, how much you have available. Right, and so some of our interventions are about if we can come into the nursing home, into the facility, care for the patient, and what we're seeing is we can help prevent the need to go to the hospital. And obviously sometimes it's necessary for medical reasons, but often we try to remove the behavioral or other reasons that sometimes prompt the going to the hospital. Anyone else? Any experiences or really anything about your work? Anything you want to share?
I do have kind of another question for you. When you're addressing the sleep patterns, is there anything in kind of jewels of wisdom from the group about how to deal with sundowners or how to promote that restful sleep and promote more normal activity patterns?
What do other people think before I jump in? How do you like to address sleep?
I think
okay.
I think sleep, and another word they use for it, recovery, is essential to brain health, as well as everything else that you do in life. And I don't think we really have taken a look at that. I mean, it's out there, we see it around, but I don't think many people look at it in the same way. And when you have a tracker and it tells you how much sleep you get every night, I've talked to other friends who began using a tracker at, over their 60s. They're always amazed by how little sleep they get.
What have people done to improve sleep, even for themselves or for their patients? What are interventions you guys have done?
So I know providers in our clinic have leaned on like Benadryl, which you have recommended against using with people with dementia, right?
Absolutely not. Yeah. Please don't use Benadryl. I'll tell you right now, if you guys want to advocate, if you absolutely need a pharmaceutical, trazodone, mirtazapine are the two options to use far and away ever before you ever. There is really no situation I'll tell you this much. I've never used Benadryl to treat sleep and dementia. It's never been necessary. So I can promise you it's not necessary. It's just the risks far outweigh the benefits. In fact, you're guaranteed to send them. They'll end up in the hospital if you use Benadryl. It just depends on the stage of disease. But moreover, if anyone just looks up cognitive behavioral therapy for insomnia, CBTI, the VA actually has a free app. The VA has actually a whole bunch of free apps. It's actually pretty nice. I mean, they're ugly, but they've got the great content. So CBTI Coach, free. I've had hundreds of patients download this. Again, it's free and the content's all on target. It's all about sleep hygiene. I'll tell you another fun fact. I've never not been able to have a patient get off of their sleep medications if they do high fidelity CBTI. If they do CBTI, I've been able to get every patient off of all their Ambiens, their Benadryls, or whatever. And so I think it was Mark that said earlier, as you age, your sleep architecture changes for everybody. It doesn't matter if you have dementia or not. Your delta deep sleep goes down, your REM sleep goes down, your sleep latency goes up, takes longer to fall asleep, et cetera. You're in lighter sleep. That's for everybody. So you never used a sound machine when you were younger? Guess what? You need to start using a sound machine. You don't keep your room cool enough? Guess what? You need to have the room cooler. Oh, you didn't use the blackout curtains? Well, you need to use the blackout curtains now because you're going to be triggered out of your sleep way easier. So you need to do all of those things. And the CBTI Coach is nice because it kind of goes over sleep hygiene. You cannot be using screens. You cannot have blue light or screen time after 8 p.m. You just can't do it. It will affect you. It didn't when you were in your 20s or 30s. And so you got away with it. And you might still think that way. But I promise you, if you're over 50, it 100% reduces your sleep. And there's no human being where it doesn't. And so guess what? We get used to, hey, I'm going to have a drink so it'll help me fall asleep. Sure. But alcohol worsens your sleep architecture. It helps you fall asleep, but your sleep remains light. You are unable to get to that delta deep sleep. That's the restorative cleansing sleep for your brain. Alcohol prevents you from doing that. That's why if anyone's drank, they fell asleep. They don't remember falling asleep, but they feel like they didn't sleep at all when they wake up in the morning, right? You feel groggy and hungover, all that, even with just a couple of drinks. That's because alcohol does not let you sleep fully. So those coping skills we use, right, even from a young age, they start to catch up to us. So that's why. So I harp on sleep a lot because the results are amazing and you feel so much better. And it's easy. You don't even, most of the time don't have to use medications. Sure. But if you need to, trazodone first, mirtazapine. If you also need someone to have a better appetite, mirtazapine can be helpful with that too. But please, anyone seeing Benadryl or any anticholinergic, tolterodine, all those bladder stuff, all that, please prompt with your providers, your medical providers, to get off anything that's anticholinergic.
Do you happen to have, just off the top of your head, like a resource for those people that are trying to address it with the providers that are prescribing Benadryl, like a quick primer or something like that to stick in?
I have one of our geriatric psychiatrists who actually developed this for the VA in Texas, has a really nice little one-pager, little pamphlet. I sent it out last year when we did the TikTok series. And so we can send that back out again if you want, Amber. It's a nice, quick little reference.
I'll get it to the rest of the group.
Sure. I will do that.
What about melatonin?
Oh, so great question. Melatonin, great medication. Now, melatonin does not affect so much your sleep drive. And that's kind of what we were just focusing on. All the Benadryls and trazodone, it's all about sleep drive. Melatonin is your circadian rhythm. You have two factors that are driving your sleep. You have your circadian rhythm, the time, and then you have sleep drive. That's why, for example, coffee messes with your sleep drive because it blocks adenosine receptors. All those Ambiens, it's all about sleep drive. Now, addressing circadian rhythm is actually great too. And for those patients that tend to be up overnight or sleeping during the day, you want to give them a low dose melatonin, 1 to 3 milligrams, whatever's over the counter. You want them to take that at dinner time, not at bedtime. When you take melatonin, the signal you're giving to your SCM, suprachiasmatic nucleus in your brain, is the sun is going down. That's what it's saying. You don't want the sun to go down at 10 or 11 p.m. You want the sun to go down at 5 or 6 p.m. Because what that means is that nucleus in your brain is then telling your brain you should be asleep in 5 to 6 hours. So people often give melatonin at bedtime, 9, 10, 11 p.m. Guess what? You're saying to your brain you should be asleep at 4 a.m. That's not what we want, or 3 a.m. So it's a commonly given incorrectly. That's okay. Just adjust that. So give it to them with dinner. That's the easiest way to do it, is give melatonin with dinner. That's the rule of thumb. There's a couple exceptions to that when we use high dose melatonin for REM sleep behavior, and Parkinson's is one, but those are exceptions to the rule. Those will give high dose at bedtime. And I'm talking 10, 15, 20 milligrams. But that's going to come from the doctor. You don't have to worry about that. But yeah, melatonin for sleep is perfectly reasonable. Any other questions?
I think you should do a whole thing on sleep just to.
We can absolutely. I love sleep. Yeah.
For all of those of us that are perhaps over the age of 50.
We can absolutely. Trust me. You should see my setup now. I've got a white noise machine. I've never had that. Yeah, I've got super dark, nice and cool. I actually like to sleep with a temperature about 62. So I let the house get pretty cold. I mean, or even colder. It just depends on what you want.
Any other thoughts from the group as far as interventions that you've used with folks to keep them safe, keep them out of the hospital, or questions that you have for Dr. Gomi? Going once, going twice. Take the expert advice when you can get it. Any other final thoughts? Guys are a quiet group tonight today. Anything else, Dr. Gomi? Otherwise, we can let people get back to their taking care of all those important patients in their lives.
Yeah, absolutely. Thanks, everybody.
Okay. Thanks. Bye-bye.
You ready? Okay. Bye-bye.